Post-traumatic stress disorder, PTSD. So the DSM-5 definition, the first requirement, exposure to actual threat or threat of death, serious injury, or sexual violence, or experience or witness the event, learn about the event from a family member or a close friend, or extreme and repeated exposure to adverse details of the trauma. The second requirement, the disturbance lasts for more than 1 month and causes clinically significant distress, or it impairs social, occupational, and other aspects of functioning. The disturbance is not due to effects from a substance or medical condition. And then the presence of one or more of the following symptoms. So recurrent, involuntary, or intrusive disturbing memories and or dreams related to the trauma, reactions where the individual feels or acts as if the event is happening again, and at that time they could possibly lose their sense of surrounding, forget where they are. A prolonged or intense distress from internal and external cues related to the event, and flashbacks to the event, physiological reactions like an increased heart rate or having trouble breathing, to external and internal cues related to the trauma. Other symptoms, avoidance of stimuli related to the event that is persistent. So, like being in a car accident, you don't want to get back into a car. Negative changes to cognition and mood, unable to remember parts of the event, dissociative amnesia, negative beliefs about oneself, others, or environment. So, maybe thinking that there's something wrong with you, that if you have been involved in like a sexual assault, blaming yourself. A continuous negative emotional state and an inability to feel positive emotions, detachment or estrangement from others, and then changes to arousal and reactivity connected to the event, irritable behavior, angry outbursts, self-destructive behavior, hypervigilance, exaggerated startle response, and problems concentrating. So the self-destructive behavior is really associated, I think, with turning to drug use. So a lot of PTSD sufferers end up with addiction from turning to drugs. And then the hypervigilance and exaggerated startle response. So just being obviously easily startled. So on a personal note, I actually was in a car wreck and have PTSD, but it happened a long time ago. But I do startle easily, and it's not as bad as it used to be. But like any little loud noise, I would just like jump and kind of go through this whole, like my heart rate would increase and I had to calm down, and it was kind of a pain. But anyway, so back to hypervigilance, like maybe being overprotective of like a loved one. So car accident, you don't want your child in a car, or you're afraid of who they ride with, you're the only one that can drive them. Those are examples of that. A sleep disturbance. And then another aspect to PTSD is the delayed onset. So that would be where the symptoms don't actually occur until like 6 months or maybe less after the event. So the event happens, and then maybe a month later they start experiencing symptoms. Prevalence. This is based in the United States, and this information came from the VA. So 6% of the population has PTSD at some point. 12 million adults a year suffering of PTSD in the US. So about 8% of women, 4% of men, 3 to 15% of female children and teens, and 1 to 6% of male children and teens. And then broken down by war. So about 11 to 20% from the Iraq War, 12% from the Gulf War, and then 15% from the Vietnam War. And they believe that women are more susceptible to PTSD, or maybe not susceptible, but there's a higher rate because of sexual assaults and sexual abuse. Causes and risk factors. Obviously, the main cause is a traumatic event, and sometimes the event is severe enough that these other factors aren't involved. But nonetheless, some genetic factors that they've found related to PTSD are types of genotypes in the serotonin transporter, 5-HTTLPR, the sorry, hypothalamic pituitary adrenal axis, and the retinoid-related orphan receptor alpha, and then decreased prefrontal volume in the brain. So abnormalities or changes to all of these aspects have been associated with PTSD. So low IQ, how that pertains to PTSD, I read in a study that they believe that those with a lower IQ or cognition are unable to uh, put like a positive meaning maybe towards their trauma. They're kind of stuck in the devastation, so they're unable to, look and think about it in different ways. A high neuroticism and a lack of social support, a previous trauma or traumas, and chronic stress, and then also having a mental disorder before the trauma happens, and that's most likely mood or anxiety disorders. Since PTSD, a major thing about it is becoming anxious. All right, treatments. Cognitive behavioral therapy is a major aspect of treating PTSD, trying to rewire the thinking. So cognitive processing therapy, they focus on negative beliefs about the traumatic event, or there's prolonged exposure where they really focus on memories or feelings or situations that pertain to the event. Eye movement desensitization and reprocessing, or EMDR. I actually had this done. So the patient focuses on a trauma memory during a bilateral stimulation, such as rapid finger movements that they follow with their eyes. So, for instance, you're sitting in a chair and your therapist sits right in front of you, and you kind of pick a part of the trauma and just focus on that memory. Usually, you try to pick something that's most distressing. And then the therapist will move their fingers back and forth really quick, and you have to focus on it with your eyes for like a minute or two, and then that'll desensitize you to that memory. That's the goal of that. Eclectic psychotherapy. This type of therapy is supposed to focus on the shame and guilt that might be associated with the trauma, so blaming yourself for the event. And then medications that have been approved to treat PTSD are SSRIs, and the particular ones are the sertraline, paroxetine, fluoxetine, and venlafaxine. So looking at some studies, in 2011, researchers looked at structure abnormalities associated with PTSD and depression because there's some overlap with those two disorders. So particular to the PTSD, anyway, so they all went through a structural MRI. And in the PTSD patients, they did find reduced volumes of gray matter in their dorsal and rostral anterior cingulate cortex, their medial orbital frontal cortex, and the dorsolateral prefrontal cortex. So the researchers took that and believe that the symptom of flashbacks is attributed to abnormal interpretations of information that comes from the two visual streams. So as the information is received separately, when it all gets put together, that's where the malfunction happens. And then they also believe that the gray volume deficiencies might explain malfunction in sensory processing, so maybe being overly sensitive, or just associating things that are safe with danger. All right, so in 2009, a study looking at genotypes of the serotonin transporter, the 5-HTTLPR, seeing if a certain genotype of that transporter would be a protective factor in PTSD. So they looked at 41 subjects who had been in a car accident, and I wanted to also mention that car accidents, aside from, going to war, so outside of that, car accidents are like the number one cause of PTSD. Anyway, so they looked at the subjects 1 month after their accident and then 12 months after the event. And they found that the S allele genotype compared to the SS and SL genotype of the transporter um, was a protective factor in the development of PTSD. Just because those that had a higher rate of PTSD had the SS and SL genotype of that transporter. So possibly if you're exposed to trauma and you have a S allele genotype of the transporter, you might not get PTSD. Anyway, 2016, looking at fear extension memory deficiencies in PTSD subjects. So, fMRI and skin conductance test was performed. So while the subjects were in an fMRI, they were shown stimuli that was supposed to be associated with safety or danger. And then during the same time at looking at one of the cues, they would shock them. That was the skin test. And then they ran a phase where they tried to extinguish the fear response to the danger cues. So essentially, the PTSD group was unable to extinguish any of their fear responses, and they had a fear response to both safety and danger cues. So they associated that with activity in their ventral medial prefrontal cortex and their amygdala. They did conclude that when talking about the ventromedial prefrontal cortex, that activity would be associated with behavioral avoidance, so trying to avoid anything related to the trauma. And references.